You are now listening to Nailed It, the Orthopedic Surgery Podcast.
All right, welcome back, everybody. We have another episode of the Citations Classic Shoulder and Elbow. Today, we're going to be talking about total elbow arthroplasty. Pretty much the same group with us. We have myself, Sam, and we also have Teja, except he has now moved on. He is now a PGY1 intern at Harvard. We still have Matt and Jalen at Ohio and Wayne State. And then we also have Alex, who is now moving on to his fellowship in Florida. And then we also added on Brad. He is a fourth-year resident at University at Buffalo. He is interested in shoulder and elbow as well, so we're excited to have him join. And then Alex, going off to fellowship, will be transitioning to somewhat of an advisor role and helping where needed. So we're excited that he's going to stay on as well and give us some insight into a lot of the shoulder and elbow stuff. Obviously, he's going on to fellowship, so that'll be a great addition to keep him on the team. We'll get right into it with the introduction into total elbow arthroplasty, and Alex will kind of give us some background on that.
Yeah, sure. So elbow arthroplasty is sort of in a stage of refinement. Now it's certainly one of the less popular arthroplasties you talk about, but still has its valuable role. Surgeons who perform these procedures usually only do a few each year on average. Recent literature has said fewer than 3 for the gross average, though there are a handful of surgeons around the country who do more, usually at high volume centers. And complication rates are most recent reported still quite high, usually around 20%. Historically, elbow arthroplasties with modern cement techniques were considered to be a good option in patients with rheumatoid arthritis, as anywhere between 20 to 70% of these patients with rheumatoid could be expected to have some amount of elbow involvement. However, with the advent of better biologics over the last few decades, the need for this has considerably decreased in these patients. Instead, now an aging population with poor bone health has created an interest in elbow arthroplasty as an alternative to open reduction and internal fixation, such as we see in the hip and even oftentimes in the knee. You can see in these charts here too how from Jenkins et al. That the number of arthroplasties overall for elbow have decreased slightly in the crossing the millennium, but the decrease in RA has largely been driving that with a slight increase in total elbows for fracture. Though we know with an aging population, we expect distal humerus fractures to maybe even triple by 2040. So elbow arthroplasty implants come in several different constraints, much like the total knee. Basically, on the left here, you see an unconstrained total elbow arthroplasty, and then moving over in constraint. So largely this depends on the desired activity level of the patient. As we heard about, the weight-bearing restrictions on these are just sort of, expert opinion and aren't really rigorously tested in any way. And also depend on the quality of the collateral ligaments. So unconstrained devices, such as the one on the left, require competent collateral ligaments. However, distal humerus fractures and RA are often associated with some disruption of these ligaments. So semi-constrained and constrained implants, such as the far right Kunrad-Mori implant and the Tournier Stryker latitude and center, offer more stability with some form of linkage between the ulnar and humeral components. So basically, constraint, most notably in the center implant, there is it's a form of linkage over the going from a half circle that articulates with the distal humerus implant to a piece that you just lock onto the back that acts as a linkage between the two. The radial head replacement isn't necessary in the constrained option of it. Otherwise, it's considered semi-constrained. But a lot of the traditional stuff that you'll even see in revision still is that Kunrad-Mori implant on the far right. It does go without saying too that the two on the right have the anterior flange, which is a big subject of debate in the more modern implants. You can always look super smart on your rotations talking about the flange effectively increases the moment of inertia, or the greater polar moment of inertia, i.e. the resistance between rotational forces. So if you put a bone graft between that, you're essentially widening that cylinder. And also these implants tend to have a lot of rotational issues, even with cement, because just the way cement sort of works in that shear force that we know in revision situations that extending that flange can make a big change to the implant stability. You can go on to the next slide. So as stated, the complication rates are most concerning with elbow arthroplasty, infection, and soft tissue complications being the most concerning, as these can be devastating in any form of arthroplasty, but are certainly less forgiving in this joint due to the relatively osteopenic bone of the distal humerus and very limited soft tissue coverage. The flaps do exist. It's not as the flaps that are used there often are more rigorous and are less commonly used. Bushing wear is something that is quite common with these, especially with knowing how the elbow works. Prior implants used to treat it as sort of just a rigid hinge, but there is some sliding motion required. In the Coonrod Moria, especially, there's a little bit of a, for lack of a better term, a slop or a play in the varus valgus of it that makes it easier to implant and a little more forgiving in implantation, but also can be a little more wearing on the bushings. Any surgery is additional surgery and comes with its risks, but bushing wear, in its most simplest form is just exchanging out a couple components. But certainly is something that you want to avoid if you can. And then lastly is triceps insufficiency, which is seen more in RA patients, but is definitely there in fracture patients. This can be up to the surgeon too, though triceps on approaches, such as paratricipital or stomp approach, they keep on the triceps to avoid that stretching out and that lack of triceps insufficiency, especially the overhead activity. So imagine raising your shoulder and trying to comb the back of your hair. That's something that can be quite concerning for patients. So next slide. Lastly, due to the complicated and oftentimes unsatisfying results surrounding total elbow arthroplasty, there are multiple alternatives. Anytime there's not a slam dunk procedure, you're going to see multiple options, but there's also multiple pathologies here. You're going to see in these articles, we're talking largely about RA because this is the classics. Using it for distal humerus replacement wasn't really, was certainly an option, but not as rigorously tested as it is now. However, you should be knowledgeable of what options are out there. So for an arthritic joint, mostly osteoarthritis, so in throwers or manual laborers who are using their elbow a little bit more. Elbow arthritis is more treated as a capsular issue or a tightness issue. So getting that range from 30 to 130 is sort of the goal here. So open and arthroscopic capsular releases and synovectomies are quite common, though these can require multiple procedures. And not that I've seen it very often, but I know it is quite rarely used, especially among a lot of hand surgeons, is this interposition arthroplasty. You're basically putting some fascial graft over the distal humerus, which do have some pretty impressive results. Again, that's for arthritic patients, osteoarthritis. In regard to fracture, more modern techniques, we know the indication or the options for here involve, the quote unquote bag of bones or just non-operative treatment, which is for the medically frail patients, open reduction, internal fixation, and then not approved in the US as of yet, but there are implants out there, and certainly articles flowing around and talked about quite a bit is distal humerus replacement. So forgoing the olecranon or the ulnar component and just replacing it with basically a hemiarthroplasty in this occasion.
Yeah, great background. I think that's really helpful and kind of frames the rest of these articles. Like Alex said, we can see, especially from that first paper that he quoted from Jenkins et al., this isn't something that's necessarily taken off like other joint replacements like a hip or a knee, or even, a partial knee replacement or a hemiarthroplasty for the hip. And we'll get into some of the data as to why that is. So without further ado, Tasia will get into some of these articles and looking at the data behind that.
Yeah. So yeah, I'll be presenting the JBJS article from 1992, kind of going into the more long-term results of using this semi-constrained arthroplasty in a population of rheumatoid arthritis of the elbow. And this study was done by the excellent team led by Dr. Murray in the Mayo Clinic. Next slide. So just as a background, this paper focused mainly on what was the second generation semi-constrained elbow arthroplasty design. Initially, there was a fully constrained design with a metal-on-metal hinge, but long-term studies have found high rates of loosening, like we mentioned in the complications. So the original first generation semi-constrained implant kind of incorporated a loose hinge and had a pin placed across the distal humerus component using like polyethylene brushes. And the second generation kind of expanded upon that with the anterior extension that was added to the humeral component. And this essentially allowed for posterior stability. And surface beds were also incorporated to enhance fixation of the cement and also the bone graft that was used in the procedure. And ultimately, the semi-constrained design it allowed for better articulation and also varus valgus laxity and internal and external rotation more consistent of what a normal elbow range of motion would be. And so this study specifically looked into the second generation design and looked into long-term outputs, specifically in patients with rheumatoid arthritis. Next slide. And so the study design was a retrospective review, looking into patients between 1982 and 1988. And ultimately, they got about 68 elbows from 64 patients. And they were indicated for the arthroplastic procedure due to refractory pain, about 91%. And the other 9% was more due to limited function or motion. And the implant used specifically was the semi-constrained Zimmer implant. And there was a small exception in patients that were young, less than 35 years, and were thought to have a good bone stock based on the x-rays. They were treated with a DePuy resurfacing device. I think we talked like previously about like arthritis and different resurfacing methods and capsular release. So that technique was incorporated and a different resurface and partial like arthroplasty was used in that population. And the outcomes that were collected, this authors introduced something called a performance index that made up primarily of pain, followed by function and motion, and then lastly, the stability of the design. And they also looked into the pre-op and post-op radiographs and kind of used a 4 grading scale. 1 was no changes other than possible presence of osteoporosis, and 2 grade was articular narrowing, and then 3 was more joint alterations, as you could see in the image in the left, and then 4 was used for just gross destruction of the elbow. And so just quickly about the operative technique and pearls that the authors mentioned in the paper. One thing they emphasized was the soft tissue release and also management of the ulnar nerve. So they recommended during the elbow arthroplasty to release the triceps from the olecranon and also translate the ulnar nerve anteriorly to prevent any neuropraxia. And then regarding fixation, they used an intramedullary injecting system to insert the cement for both components and also place the bone graft between the anterior extension of the implant, which was the new second generation design, and then the distal humerus. And finally, they used the pin that allowed for the semi-constrained design and put it between the 2-part device with a split ring for fixation. And they did have one patient that we'll go into later that had an injury with the triceps. So they altered their technique and found good success by reattaching the triceps through a crisscrossed and transverse drill tunnel that you see in the picture below, with the elbow kept at 90 degrees. And so looking at the results, on the table on the left here, you see dramatic improvement in the pain about 85% of the patients who had this procedure done, again, in the rheumatoid arthritis population, had no pain postoperatively. And this is all at a mean follow-up of 3.8 years. And when you look down and see the stability as well, you see a dramatic increase in the stability of the elbow. And again, the performance index score that incorporates both stability, function, motion, and pain improved from an average of 38 to a 94 out of 100. So excellent outcomes at, again, mean follow-up of 3.8 years. In terms of complications, the study found a rate of 22%, so about 15 patients that had 6 reoperations. And the main ones are listed on the down below. Most of them were intraoperative condylar fractures and infections. And there are other ones in terms of the ulnar nerve, paresthesia, and then avulsion of the tricep, like I mentioned before. And then the Kaplan-Meier Kaplan-Meier analysis below found, again, excellent probability of survivorship going up to 7 years. The vertical line show the 95 confidence interval, so well above 90% probability that this implant will survive 5, 6, 7 more years. So the conclusion, this semi-constrained total elbow arthroplasty design in a population of rheumatoid arthritis offers excellent long-term results. However, again, given how the patients were selected for the procedure, it's important that you look into the bone stock and the stability already present in these patients and consider if they are a candidate for this design versus a resurfacing. And overall, like just thinking mechanically, the loose articulation of the semi-constrained design, it allows for inherent stability as well as absorption of the varus and valgus stress and axial forces that you experience on the forearm by the muscle and ligament structures. And the techniques as well minimize the transmission of stresses to the bone cement interface.
Yeah, great summary. I think I don't really have much else to say. That was well recapped. And we can hop right into the next article. Again, we'll see a lot of kind of recurring themes with some of the big names in elbow surgery here from these articles.
Yeah, so really good job with the last article. And then this article that I had was kind of a follow-up to that with a little bit longer term follow-up. So this one, yeah, so you can go to the next slide, Slam. So just for the background, a lot of it was kind of already touched on the previous article, but the early fully constrained prosthesis for total elbow arthroplasty had disappointing results with high rates of loosening, and there's also been reported to have high rates of instability with resurfacing type implants in patients with rheumatoid arthritis. So the semi-constrained prosthesis design was developed to help address this. And as we saw in the last study, it did a pretty good job of this at short to midterm follow-up. So the purpose of this study was to evaluate the Coonrad-Mori semi-constrained total elbow prosthesis in patients who were treated for end-stage elbow arthritis who had rheumatoid at 10 to 15-year follow-up. So similar to the prior study, but a little bit longer term follow-up here. So the authors performed a retrospective review of patients with RA treated with the Coonrad-Mori total elbow prosthesis. They had 78 elbows in 68 patients. 17 of these had had a prior operation. 12 of them had a total elbow with a different implant. 4 of them had ORIF, and 1 of them had resection of fracture fragments. In terms of surgical approach, 68 had the Mayo approach. 10 of them had the triceps split. And then 68 had subcutaneous translocation of the ulnar nerve, like was described in the last study, and 10 did not. 75 were cemented, 3 were uncemented, and then the patients were divided up into either group 1, who had greater than 10 years of follow-up, and group 2, who had less than 10 years of follow-up. Outcomes that the authors looked at, similar to the last study, were implant survival, the Medial Elbow Performance Tool, and then they evaluated the elbows radiographically for any signs of loosening as well as bushing wear. And you can see how they measured that radiographically in the X-ray on the right side of the screen there. And then they also looked at complications. So for the results in terms of implant survival, they had a 94.4% survival rate at 5 years and a 92.4% survival rate at 10 years. So pretty good survival rate. 95% of the elbows had a satisfactory result. So 74 of the 78 there. And that was based on the Mayo Elbow Performance Score. And then in terms of pain, 97% of the elbows were classified as either not painful or mildly painful. All of them had a significant improvement in pain following the surgery, with the exception of the 2 patients who did have to have resection arthroplasty. And we'll get into that when we talk about complications. And then for range of motion, the patients all had a significant increase in flexion, extension, pronation, and supination compared to preoperative levels. For the flexion and extension arc, they gained about 13 degrees of motion from preoperative to post-op levels. One thing to note here is that even though they did have a significant increase and everyone felt that they improved, is that they still don't have a full flexion and extension arc. Although the arc that they all had was considered to be functional, a lot of them still do lack terminal extension there. And then looking at stability, no patients with the intact prostheses had any subjective or objective instability. And then for daily function, they all had significant increase from preoperative evaluation in their levels of daily function. Continuing on with the radiographic evaluation, in terms of radiographic loosening, 2 patients were found to have loose ulnar components. One of them was secondary to an infection, and the other was just found on radiographs, and the patient was asymptomatic from this. And then 11 patients had signs of bushing wear, 5 of these partial and 6 complete. For complications, there were 11 total, so 14%, 3 triceps avulsions, 2 deep infections, 2 ulnar fractures, and then 2 were revised for aseptic loosening of the implant. The 2 that did have the deep infection, both of them had to undergo resection. So obviously that's a pretty significant complication there. And then just getting into the conclusions that the authors make, they do state that the total elbow arthroplasty with the Coonrad-Mori implant for patients with rheumatoid arthritis can provide reliable pain relief, improved range of motion, and good to excellent outcomes at 10 to 15-year follow-up. That being said, obviously, these patients are still limited by the weightlifting restrictions post-operatively that come with total elbow arthroplasty. And then we also have to keep in mind still that while the complications that they reported were relatively rare, some of the complications such as infections can have unsatisfactory results and potentially devastating outcomes, as both of the patients with infections did eventually have to undergo complete resection.
Fantastic. Yeah. So I think that's a great recap of kind of the, obviously big name in elbow surgery is Dr. Mori, and seeing that this is a good option, at least for patients with RA. So now kind of transitioning again, looking at another one of his papers in JBJS from 1997. We're looking now at total elbow arthroplasty as a treatment for the distal humeral fractures in elderly patients. Again, we kind of mentioned that this is used pretty often in RA, especially in the earlier years, and now starting to be used for treatment of the distal humeral fractures. So some background, distal humerus fractures treated with open reduction and internal fixation had pretty high complication rates at the time. Approximately 25% of patients were unsatisfied with their fixation. And at this time, total elbow arthroplasty had not been considered as an option for the treatment of especially comminuted fractures of the distal humerus, primarily because outcome was unpredictable. But these prior studies that the same group did showed that at least for RA patients, these seem to have pretty reliable outcomes. So kind of using that and extrapolating it to distal humerus fractures now. But they said that long-term follow-up for acute fracture using total elbow aren't available because obviously, like I mentioned, not a lot of them are being done. But again, they have been shown to be viable for other things such as RA or post-traumatic deformities of the elbow in some patients older than 60 years old. So the study design they utilized was a retrospective review of patients from 1982 to 1992. They specifically said that they carefully selected patients, and their study size was pretty small. They only had 20 patients, 21 elbows that had distal humerus fractures. They had 125 total patients that had distal humerus fractures at that time, 129 total elbows, and 20 of those underwent total elbow versus ORIF or non-operative treatment. They said that they only performed total elbow in the absence of any suitable alternative treatment. And the indications they used were pretty strict again. So they said that it had to be extensively comminuted acute fracture of the distal aspect of the humerus. That was in 9 patients, 10 total elbows, with destruction of the articular surface due to RA and a comminuted intra-articular fracture in patients older than 65 years old. And that was 11 of their patients. And they specifically stated that having rheumatoid did influence their treatment choice because this is specifically a disease of joints that's usually treated with replacement arthroplasty, at least in this group's hands. So this was not randomized by any means. These patients were, again, carefully selected. Their average age was older, 72, but they did have a range from 48 all the way up to 92 years old. And the average age of all of their 125 patients with distal humerus fractures at that time was 49. So again, you can see that the total elbow group is significantly older. And they said that the average time to surgical fixation was about 7 days, and they did obtain follow-up for approximately 3.5 years. They stated that all their implants were intact at the last follow-up, and all of their implants were cemented. But all of their patients also had a flexion contracture ranging anywhere from 5 degrees to 45 degrees. And like most elbow surgeries, one of the biggest complications is loss of terminal extension. So overall, not very surprising, but kind of consistent across the board that they all had flexion contractures at least a little bit. Using the same performance score that they had discussed in the other papers, where there's, measures for pain, function, motion, and stability. They had 15 elbows with excellent results, 5 with good results, and 1 had inadequate data to determine it. So none of them had poor or fair results. The average post-op range of motion was 25 to 130, which is pretty good considering that, a functional range of motion of the elbow is approximately 30 to 130. So essentially all of these patients had functional range of motion of their elbow. But obviously, like we mentioned before, had that post-op restriction in terms of how much they were able to lift weight. For their complications, they did have 1 that required a revision, 3 that had ulnar neuropraxia, 2 of those self-resolving. 1 patient had reflexive sympathetic dystrophy. They had 1 pulmonary embolism on post-op day 1. They had 1 stroke intraoperatively, 1 heart attack intraoperatively, and 1 superficial wound infection, as well as 1 fibrous non-union. So overall, only 20 patients, and a decent amount of them had some kind of complication. But again, it seems like the patients that they were selecting for this procedure weren't overall the healthiest patients to begin with. The 1 revision total elbow arthroplasty was for a patient who was 20 months post-operatively and then had another fall and fractured around their ulnar component. So their conclusions from this paper was that total elbow arthroplasty can be an alternative form of treatment, specifically for severely comminuted fractures of the distal humerus in older patients in the presence of RA. However, they say that experience with the total elbow system should be considered a prerequisite for surgeons performing the operation. Again, this is Dr. Warren. He's, obviously one of the pioneers of this surgery and a giant in elbows. So you don't just want any general orthopedist, putting in their first total elbow for extremely comminuted distal humerus fracture. And again, 21 procedures were performed during this 11-year period, and it emphasizes the strict criteria for selection. So essentially, they were doing 2 of these procedures per year. And again, just kind of emphasizes, at least in the early years, about their strict criteria for using this system, which has kind of continued on to this day. Again, not something that we generally see very often.
Yeah, Sam, I just comment on that too. I mean, that's sort of the big thing for people who are, listening to this and all that, is to actually like look at those indications, which are certainly changing actively for the distal humerus indications, as far as fixing distal humerus fractures. But that it's really a technically demanding procedure. And, the big thing is like, what is low demand? I mean, that's what everybody has trouble with in residency and med school and all that. And even, out in the practice, what is low demand? And that's certainly going to change. But like, like I said at the beginning, and like, you kind of showed with their experiences, like there's not anybody who's necessarily, aside from a handful of surgeons across the country, who are technically doing a lot of these. Like, the literature says that I believe it's like 50 total knees a year, like makes you, kind of on par with the, more higher volume surgeons for total knees, but like no one's doing 50 total elbows. And those certainly require a lot, but have more complications and everything. So it's tough, but, the incidence of this is going to increase, and, maybe people will be getting more exposure. Who knows?
Absolutely. Yeah, that's a great point. And speaking of, a great segue, Alex will be training with Dr. Frankel next year. So we'll hop into his article, one of the newer big names in shoulder and elbow surgery.
Yeah, for sure. So this is Jalen. I looked at an article by Dr. Franklin looking at a comparison of RF and primary TEA and the treatment of intra-articular distal humerus fractures in women older than age 65. This is published in JLT in 2003. So more on the background that we already know, that we've been talking about throughout this podcast. Around this time, distal humerus fractures actually accounted for about 2% of adult fractures. Treatment options back then, we included osteosynthesis, RIF, non-op, and TEA was just new on the scene. But for those other treatment options, they all were providing suboptimal outcomes and complications that included hardware failure, heterotrophic ossification, nerve entrapment, post-traumatic arthritis, and mal and non-union. Previous studies demonstrated that women less than the age of 65 years old with intra-articular distal humerus fractures and suffered worse post-operatively compared to their counterparts. So the purpose of this study was to compare RF and TEA with intra-articular distal humerus fractures and women older than age 65 years old. So the study consisted of 24 females, 24 total elbows. They were all older than 65 years old and sustained a distal humerus fracture. This is a retrospective study done at a single level 1 trauma center. There are 12 elbows placed in the RIF group and 12 elbows placed in the TEA group. All fractures were identified as a 13.C2 or 13.C3 for OTA classifications. No fractures were open or any neurovascular compromise. RIF elbows were treated by traumatologists, and TEA elbows were treated by shoulder and elbow trained surgeons. All patients had at least 24 months of follow-up. In terms of the study design, the average age for the RF group is 74 years old. The elbows fracture patterns consisted of 4 13.C2s and 8 13.C3 fractures for the OTA classifications. The average time surgery is 2 days. 3 of these patients had osteoporosis, and 10 of the 12 elbows required electron osteotomy. The remaining 2 used the tricep sparing approach. For TEA group, the average age is 72 years old. 4 elbows were 13C3s and 8 were 13C, which couldn't be further classified due to rheumatoid destruction that affected all the elbows. All patients in the TA group had osteoporosis. Time of surgery for the TA group on average was about 8 days, and they all used the semi-constrained cemented total elbow implant done by Zimmer. Primary outcomes of this study looked at the Mayo elbow performance score that we talked about earlier, as well as pain, patient satisfaction, flexion, extension, range of motion, and complications that were associated. looking at the results of this study, and when looking at the ORF group, the average follow-up time is 57 months compared to the TA group, which was 45 months. TA group had a lower operative time at 90 minutes, average at 90 minutes compared to the ORF group at 150 minutes. And TA group also had better Mayo performance scores with 11 scoring is excellent and 1 is good compared to the ORF group, which had 4 rated as excellent, 4 rated as good, 1 is fair, and 3 is poor. For the patients that were reported as poor, all 3 resulted in fixation failure that required revision to a TEA. The average arc of flexion and extension for the TEA group was 113 degrees compared to the ORF group, which was 100 degrees. The average Mayo score for the TEA group was 95 points compared to 87.7 points for the ORF group. Statistical significance was not looked at due to the small sample size of the study. So in conclusion, when we look at the results of the study, we noticed that patients treated with TA scored higher on the Mayo score than the patients treated successfully with ORF who did not undergo revision. However, outcomes of distal humerus fractures in patients treated by both ORF and TA demonstrated that either could restore function when looking at the arc ranges of motion and as well as providing pain relief for these patients. TA was preferred for comminuted and displaced intra-articular fractures in older women with comorbidities, including rheumatoid arthritis. ORF was preferred for patients with adequate bone stock and without comorbidities. When looking at these patients, this study kind of put together a flow chart that I'll kind of entail, but you can see if you go and watch the podcast online on YouTube. But starting with distal humerus fractures in women aged older than 65, then broken down into comorbidities, whether they had few or multiple, which included rheumatoid arthritis. For patients with few, that was then segued into poor bone versus good bone. If they had good bone, they were a good candidate for RIF. If they had poor bone, then they would consider TEA. Going back up to comorbidities, if they had multiple, which could include rheumatoid arthritis, it was then again subclassified into poor bone versus good bone. For poor bone, they considered TEA. For good bone, they considered ORIF, unless other comorbidities were associated, which then they would consider TEA, such as if rheumatoid arthritis is associated. For the outcomes of this study, conclusions are limited due to the small sample size of only 24 patients and due to the TEA population having 67% having rheumatoid arthritis. But in all, we're able to see that TEA was a suitable outcome and treatment option for these patients that experience distal humerus fracture.
Okay, and just to round us out here, it's Matt presenting the last article published in 2009 in JSES titled A Multi-Center Prospective Randomized Controlled Trial of Open Reduction Internal Fixation versus Total Elbow Arthroplasty for Displaced Intra-Articular Distal Humeral Fractures in Elderly Patients, published by McKee and al. So just as a background, as we previously stated, open reduction internal fixation with plate fixation was shown in the literature to be the gold standard for displaced intra-articular distal humerus fractures in young patients. Conversely, elderly patients had less predictable outcomes with open reduction internal fixation due to numerous factors, including osteoporotic bone, metaphyseal comminution, poor soft tissue conditions, as well as limited tolerance for joint immobilization, as we previously touched on in the previous articles. Primary TEA showed to be a viable treatment option for older patients, but the recommendations were based only on retrospective reviews from single institutions at the time, as we previously demonstrated in the previous article presented by Jalen. Thus, the author set out to conduct a prospective randomized control trial comparing the functional outcomes, complication, reoperation rates, and open reduction internal fixation versus primary TEA for the treatment of displaced comminuted intra-articular distal humerus fractures in elderly patients greater than the age of 65. The primary outcome measures of the article was to look at the reoperation rates, and then secondary outcome measures were looking at patient functions using the Mayo Elbow Performance Score, which will be denounced in MEPS as we talk about it later, which was previously validated as we showed in the previous articles, as well as the disabilities of the arm and shoulder and hand instrument or DASH score. So just to look at the study design further, once again, this was a prospective randomized, double-blinded, randomized control trial at 4 academic centers in Canada. The inclusion criteria for patients included an age greater than 65, displaced comminuted intra-articular fracture of the distal humerus, and closed Orgis-Dio-Anderson grade 1 open fractures treated within 12 hours of injury. Their study included 42 patients that were randomized, but 2 of them died before follow-up, thus they were excluded. Ultimately, during the allocation, 5 patients in the open reduction internal fixation group were then converted to TEA due to extensive comminution during the operative procedure. Thus, we had 15 patients with a mean age of 77 placed in the ORF group and 25 patients with a mean age of 78 in the TEA group. And we can see the treatment allocation kind of schematic shown in figure 1 to the right there, if we're more visual learner and watching online. They also looked at baseline demographics for mechanism, classification, comorbidities, fracture type, activity level, and ipsilateral injury. And these were all denoted to be similar between the 2 groups in the randomization process. They also looked at, once again, at the metrics studied. Primary outcome, again, was the reoperation rate. And then secondary outcomes were these patient outcomes, including MEPS and DASH scores taken at 6 weeks, 3 months, 6 months, 12 months, and 2 years. And then they also looked at complication type, duration, management, and treatment requiring reoperations were recorded. And then finally, the authors performed an intention to treat analysis and on-treatment analysis were used in the patients who were randomized to ORF but were converted to TEA intraoperatively. So looking at the results, the authors noted that operation time averaged around 32 minutes less in the TEA group in comparison to the ORF group, which was shown to be statistically significant. So very similar to previous article presented by Jalen, we could see that, in a skilled surgeon, shoulder elbow trained, they could perform a quicker procedure. Also, patients who had underwent TEA had better MEP scores at 3 months, 6 months, 12 months, and 2 years, which was to be shown to be statistically significant, as shown in figure 2 to the right. They did show that the MEP scores were better in the TEA group at that 6-week, but it was not statistically significant. And they also showed that patients who underwent TEA had better DASH scores at 6 weeks and 6 months, as shown in figure 3 to the right, to be statistically significant, but not at 12 months and 2 years. And then looking at flexion extension arc, as we previously talked about, this study also concluded that flexion extension arc was shown to be for 107 with the patients with TEA and 95 for the patients with the ORF, but was not statistically significant. And then finally, in terms of reoperation rates, we can see that 12% of the patients in the TEA group had a reoperation compared to 27% for open reduction internal fixation. So just final conclusions of the article that we could draw and that the authors presented. TEA for the treatment of comminuted intra-articular distal humerus fractures showed to be more predictable and had improved 2-year functional outcomes compared to ORF based on MEP scores. In terms of DASH scores, they were better in the TEA group in the short term, but not statistically different at 2 years follow-ups. Furthermore, the trends showed that TEA may result in decreased reoperation rates and improved range of motion, but this did not show to be statistically significant within the study. Some potential weaknesses of the study included a smaller sample size, as well as only a 2-year follow-up, so not really looking at these patients longitudinally 10 to 20 years down the road. Furthermore, the authors hearkened on this idea that the elderly patients had increased baseline DASH and appeared to accommodate to objective limitations and functions with time, as we can see within the article. And then finally, just one of the main takeaways of this article is that TEA is a preferred alternative for open reduction internal fixation in elderly patients with complex distal humerus fractures that are not amendable to stable fixation with ORF.
All right, fantastic. I think that was a pretty good overview of total elbow arthroplasty. Again, not one of the most common procedures that we do, but does seem to be a good option in the specifically chosen patient. Unless anyone else has some closing comments, we'll leave you with that. Thank you again for everybody tuning in. Hope you check out some other episodes from Nailed It Ortho, and check out some of our other Citations Classics in shoulder and elbow.